Okay, we're just going to wait until, oh, there we go, 9 a.m. All right, I'm going to start the webinar. All right, Chair, you may call today's meeting to order.
So we'll call the meeting to order. Can we proceed with the roll call, Melinda?
Absolutely. Thank you, Chair. Commissioner McAllister.
Good morning, present.
Good morning. Thank you. Chair Khan.
Present.
Thank you. Commissioner Roe Dugan.
Present.
Thank you. Commissioner Grady.
Good morning, present.
Good morning. Thank you. Commissioner Van Helling.
Present.
Thank you. Commissioner Bond.
I'm here. Good morning.
Thank you. Good morning. Commissioner Tyler Garner. And Commissioner Winkler is excused. Vice Chair Rubelin.
Good morning, present.
Good morning. Thank you. And Commissioner Ralston. Commissioner DeSerbo.
Morning, present.
Good morning. Thank you. And Commissioner Khan. Do not see her as well. Okay, now we'll move on to the ex officio members. So in today for Director Whitley, we have Deputy Director Marla McDade Williams.
Good morning.
Good morning. Thank you. And Commissioner of Insurance, Barbara.
Morning.
Good morning. Thank you. And Executive Director Ryan High.
Present. Thank you.
Thank you. And then the Executive Officer for the Public Employees Benefits Program is excused today. Chair, you do have quorum. You may call the meeting to order.
Thank you. So we'll proceed with the agenda items. Number one on the agenda is for possible action approval of November 16th, 2022 minutes. Do I have a motion for this?
Commissioner McAllister, I make a motion to accept.
Is there a second?
I think Mason's trying, but I'll second.
Motion to approve the.
All right, any opposed? If not, the motion carries. Minutes stand approved. Public comment, Melinda, do we have any public comment present or submitted in writing before?
Yes, the commission did receive a written public comment for today's meeting from the Nevada Hospital Association and the Nevada Association of Health Plans, which were sent to the commissioners on December 15th and the 20th, and also are posted to the PPC website. For those who would like to provide public comment today, if you are using the Zoom feature, please use the raise hand feature. And if you are calling in, please press *9 to raise your hand for public comment. And for public comment today, I do see we do have Mr. Patrick Kelly. Please go ahead, Pat.
Good morning. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. I'd like to address issues raised in the PPC slide deck beginning on slide 10. Because of time limitations, I'm only able to address 3 points. First, slide 12 makes the point that healthcare costs in Nevada have slightly increased faster than the incomes of Nevadans. Nevada healthcare providers purchase goods and services on a regional and national basis. We pay the same price for drugs and medical supplies that's paid in the higher income states such as Connecticut and Massachusetts. We compete regionally and nationally for nurses. Healthcare providers have no control over many costs. We wish our costs were based on the incomes of Nevadans, but they are not. Forbes reports that Nevada had the third lowest increase in overall healthcare expenditures per person over a recent 5-year period. That's very positive. We're performing well nationally. Second, slide 13 raises the issue of high deductibles. Deductibles in combination with co-payments represent the out-of-pocket cost of healthcare. High out-of-pocket costs can cause people to forgo care and not be able to pay their deductibles and co-pays. It often leads to medical debt. Frequently, hospitals and other healthcare providers receive no payment from patients with high deductible plans. Spending time evaluating the role of deductibles and co-payments is needed. when a high percentage of people indicate they avoid receiving care because of out-of-pocket costs. Third, we must examine why many Nevadans fail to take advantage of the Medicaid and low-cost insurance programs available to them. It's estimated that 83% of uninsured Nevadans are eligible to participate in either Medicaid or the Silver State Health Insurance Exchange, and they don't participate in either. Focusing efforts on enrolling these individuals would help reduce the number of people deferring care because of cost and affordability. As we enter the new year, we should address the worst statistic of all in Nevada, access to healthcare. We're ranked 50th in the country. More money must be spent to expand access to healthcare in federally designated health professional shortage areas. Access will not improve if reducing healthcare spending is the state's primary focus. A balance must be reached. Thank you for your attention, and I wish you all a happy and healthy new year.
Thank you. Anybody else for public comment?
I am seeing no other hands raised, Chair.
We can then proceed to our next agenda item. This is an informational item, update on investigation concerning an 11/18/22 news story showing a Valley Hospital Medical Center patient who was allegedly assisted by security out of the emergency department and across the street, and then left on the sidewalk adjacent to University Medical Center. So we have people from the Department of Health and Human Services here today to give us an update on the status of the investigation.
Yes,
good.
go ahead,
Thank you.
Paul, sorry.
Good morning, Chairman Khan and members of the commission. I'm Paul Schubert, Chief of the Bureau of Healthcare Quality and Compliance. And HCQC is the state survey agency responsible for periodically surveying and investigating complaints of medical facilities in Nevada for compliance with federal and state requirements. I have some prepared remarks, and I'd like to read those to the commission. And then if the commission has any questions regarding processes, I'd be happy to respond at the direction of the chairperson. So when I was requested to provide a presentation for this agenda item, I was hoping that we would be further along in the investigation process. However, both the federal and state complaints regarding Valley Hospital are still under investigation, so I cannot speak to any of our findings at this time. However, I can describe the situation, our processes, and provide explanation of some statutory and regulatory terms. As many of you are aware, on November 18th, Channel 3 News in Las Vegas published video footage of alleged Valley Hospital security staff assisting a patient across the street and then leaving the patient on the sidewalk outside of University Medical Center. In the video, the alleged patient is seen lying on the sidewalk next to an assistive walking device. It was also alleged that subsequently UMC assessed and admitted the patient. A number of elected officials inquired whether an investigation of the circumstances would occur. HCQC is investigating this case and other related complaints at Valley Hospital. Since Valley Hospital is deemed by an accrediting organization to be in compliance with federal regulations, HCQC began its investigation by reporting the allegations to the Centers for Medicare and Medicaid Services in order to obtain authorization to conduct a federal investigation. CMS did authorize HCQC to conduct a federal investigation. The ongoing investigations are reviewing facility practices for possible violations of the Emergency Medical Treatment and Active Labor Act, which is commonly known as EMTALA, and state and federal hospital discharge regulations and conditions of participation. In response to the use of the media, in response to use in the media and others using the term patient dumping, we have explained that this is a slang phrase, as the term is not defined in statutes or regulations. The term patient dumping is also commonly associated with EMTALA requirement. However, in order for an EMTALA violation to occur, several criteria must be met. One of those criteria is The patient must be suffering from an emergency medical condition upon arrival or during assessment at the hospital. An emergency medical condition is defined in the Social Security laws as a medical condition manifesting itself by acute symptoms of sufficient severity such that the absence of immediate medical attention could reasonably be expected to result in placing the health of the individual in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of any bodily organ or part. With respect to a pregnant woman who is having contractions, that there is inadequate time to effect a safe transfer to another hospital before delivery, where that transfer may pose a threat to the health or safety of the woman or the unborn child. Interpretive guidance further describes emergency medical condition as patients with diagnoses presenting with complaints which may be associated with cardiac, respiratory, high fever, loss of consciousness, rupture of membranes, or suicidal ideation. I provide these explanations so everyone will understand that EMTALA is about emergencies. EMTALA is not necessarily associated with patients suffering from chronic conditions or conditions that do not seriously jeopardize the health or cause impairment or dysfunction of an organ or body part. HCQC has not received an EMTALA complaint from UMC, the hospital that subsequently admitted the patient. I mention this because the federal regulations and guidance indicate that a hospital must report within 72 hours to the state survey agency or CMS anytime it has reason to believe it may have received an individual who has an unstable emergency medical condition from another hospital. In fact, if a recipient hospital fails to report such a situation, the recipient hospital may be subject to termination of its provider agreement. Regardless, as noted previously, HCQC is investigating for possible EMTALA violations. Beyond EMTALA, there are federal and state hospital requirements associated with discharge planning. The federal requirements are found under the condition level requirement of discharge planning in the Code of Federal Regulations, and the state requirements are found at Nevada Administrative Code 449.332. As described earlier, these complaints, both federal and state, are still under investigation, so I cannot provide information about findings at this time. However, once the investigations are complete and pursuant to any citations, the facility has had an opportunity to provide a plan of correction. The results of the investigations are made available to interested parties and the public through our website under the Division of Public and Behavioral Health. If citations of regulatory noncompliance are made, then depending on the level of the citation or the severity and scope of the citation, HCQC and CMS may take additional actions to ensure the facility resumes compliance and to encourage the facility to maintain ongoing compliance with requirements. Chairman Khan, this concludes my prepared remarks, but I am available to respond to any questions you or members of the commission may have.
Thank you. I would request the commissioners to please raise your hands, and Melinda, if you could kindly recognize as they do if they have any questions. As we were just told, this is an ongoing investigation, so obviously not too much elaboration is expected or will be available at this time.
Absolutely, Chair. Thank you. I do see Commissioner Bond, your hand is raised. Please go ahead.
Thank you. And thank you for the presentation. I think based on what you just said about UMC's response to this issue, it'd be great if next meeting we could get an update from, I don't want to put our commissioner on the spot, Mason, but it would be great if the next meeting Mason could tell us, if he's willing, a little bit about UMC's experience with this, number one. My second comment would be, I'm glad that some of this is being, I'm glad that you're trying to help us understand EMTALA, and it's good that there's other state regs that we can all review. But I think as a Patient Protection Commission, this should be like this should actually never, ever occur. So what would be really helpful, instead of defining this as not patient dumping because it doesn't meet an EMTALA definition, which it sounds like might be one of the things being considered. It would be great if you guys could come back, if DHHS could come back with what are the suggestions for remedy to never let this happen again, and what do we need to do to empower the state to be able to take action that's more definitive and creates a zero tolerance environment in Nevada for this kind of activity. Those would be my two suggestions. I'd love to hear from Mason, and I'd love the state to recommend how to make this never happen.
Thank you, Commissioner Bond. Anybody else wants to comment? Melinda, do you see anybody else interested in a comment?
Yes, I do see Commissioner Grady. Please go ahead.
Good morning. I was just wondering, do you know how long the investigation will take and when you will be able to report back to us with additional information from your investigation?
Absolutely. Because we are dealing with a federal investigation, and in this circumstance, even though we may finish our investigation and provide recommendations to CMS. CMS then makes a determination and will actually send the results to the facility. And then the facility has an opportunity to respond. So I can't speak to how long it will take for that part of the process to occur. Usually it occurs very quickly. Within a week after we send our results to CMS, they send the results to the facility. With regards to the state side of the process, we're still conducting interviews, and we will probably complete that process this week and be able to provide our results next week. So I'm thinking within 2 weeks, both the federal and the state results should be available.
Keep in mind, we have the holiday season, so it may not be in the next 2 weeks. So, but anyway, any other commissioner has any comments?
Yes, Chair. I do see Commissioner Roe Dugan. Please go ahead.
Thank you so much. So as a patient representative, I would be amiss if I didn't speak up and support Commissioner Bond on her suggestions. And also, I would like to ask, given that there is no state policy against actions like this, what would be a repercussion from this investigation? What could happen?
You want to answer that?
I certainly would like to. With regards to what encouragement we would have for the facility to comply with regulations and not have this happen again, we have state sanctions available. There are monetary penalties that we can apply. Again, it will be depending on the scope and severity of the issues that we identify. And so there are the state sanctions available. And then for the federal citations that we may have, the facility, if it's cited at a condition level requirement, the facility will be put on a termination track. So their contract to receive reimbursement from CMS would essentially be terminated after a certain period of time. Now, most facilities bring themselves back into compliance, and we do a re-inspection of the facility to see that they are in compliance before they are ever actually terminated. But those are the available sanctions and enforcement actions that we have.
So as I understand, just a quick comment, the facility has to provide an action plan that they would plan to implement to you, if I understand correctly. And then you go back, if that action plan is acceptable to you, then you go back in 3 months or so to confirm that the action plan has been put in place and it's working.
That's correct, especially with regards to the CMS process. It's actually within 90 days, so it's before the 90th day if it's at a condition level requirement that CMS makes a citation.
All right, thank you. Anybody else commenting? Linda?
Yes. Yes, Chair. We do have Commissioner Van Houweling. Please go ahead.
Hi, good morning, everyone. And obviously, this is a current active investigation, which UMC is complying with immediately on that Monday morning. Again, a watchful eye of Channel 3 News team caught this. They were actually there at the hospital doing a feel-good story with our burn therapy dogs and a patient, and kind of caught this. So obviously, I have to keep my comments limited in regards to the investigation, but we have provided all the medical records, public safety reports, video that we would have. At minimum, I would just say that we believe this was clearly an unsafe patient discharge of this patient, and just really a lack of humanity towards a fellow Las Vegan and Nevadan. So that obviously, I think everyone saw my comments, and again, this patient did require medical treatment beyond the corner of a public street, and subsequently happy to report that this individual has been reunited with her brother and her daughter. And really my point in all of this is taking a little bit more time to understand patients' needs, their story, communicate with them. Just hearing them out can actually help another human being. So a lot more to this story that people don't realize, but she is definitely in a safe location right now and getting the attention and medical needs that she needed. I would, just as a point of education, I think the Salvation Army and organizations like Catholic Charities often get caught in the middle of these type of patients where they are homeless or they don't have shelter, but beyond their scope of medical care. So certainly I appreciate all the work and efforts they do, but also lots of things happening where patients are being left outside their organizations, more than I've ever known beyond this story. But again, from my standpoint, Mason Van Houweling's personal opinion, this was an unsafe patient discharge that did require medical attention of this patient. And again, just spending a little time and listening to our patients can actually have a very good outcome in some of the worst times. So again, I apologize for being a little vague on the investigation, but from 7:30 that Monday morning, we were actively working with the state of Nevada, and we appreciate their thoroughness in any type of event throughout our state.
Thank you, Commissioner Van Houweling. Anybody else has a comment? Melinda, you see anyone?
Yes, Commissioner Bond, and then we have Deputy Director Marla Williams.
Okay.
Actually, my next question might be resolved by whatever Ms. Williams says. So why don't I hold? I'll go after her. Thank you.
Thank you, Mr. Chair. For the record, Marla McDade Williams, Deputy Director, Department of Health and Human Services. I just wanted to thank Paul for Mr. Schubert for his presentation today. I don't want anyone to leave the meeting believing that we don't investigate complaints. We investigate under state authority, as Mr. Schubert said, as well as federal authority. The importance of every investigation is to ensure that we're looking at the correct issues that are available to us. In this case, was it a situation of a patient not being treated, and we also have to be considerate of the patient and what their expectations are and what their desires are. So I just didn't want to leave anyone with the impression that we don't respond. We have a very active complaint system. We take anonymous complaints. We take complaints that are very direct, and the staff do a great job of assessing the issues and ensuring that we apply within the authority that we have under the statutes and regulations and federal law. As you know, every legislative session brings a new host of issues for us to consider. And as the legislature moves forward and declares policy and declares law, then, our staff adapt and make changes as necessary. There's the sanction process. You assess scope and severity. How often does a situation happen? Is it an isolated situation? So all of those things go into consideration in any investigation, and that's simply what I wanted to leave the members with. Thank you.
Thank you very much. Anybody else? Barbara, you wanted to follow up? Do you
Thank
have
you.
any additional comment?
Yes, I do. Thank you. Appreciate the time spent on this. I think you're kind of going where I was trying to absorb this. Marla McDade Williams. So thank you. I think we need a list again of what remedies could the state propose that would allow them to respond to this completely and comprehensively. If EMTALA does not cover what is needed and the state regs currently do not cover what is needed to make sure this never happens at a specific hospital level, as a hospital ownership entity level, Valley is one of 7 hospitals that are under the control of UHS, that UHS owns. 7th one that's currently being built. So I think it's the whole company. I don't know if there's any remedies for a company that does this. So that's 2. And then I also think this issue of how frequently this happens really needs some work around it, because from what Mason just said, this happens, and there's no singular reporting system to make sure we're capturing the data in order to take action. So I would love thoughts and support from the commission on how to gather this data.
So if I may comment, the federal government, and I'm sure the state, I'm familiar with the CMS, they come to inspect hospitals, et cetera, for their certifications on an ongoing basis. They, other than EMTALA, they do review the case management plan for each hospital, that they have a safe discharge plan for the patients. And so if something like this on investigations, even if it suggests that the discharge plan was safe, then in their judgment, the investigators, then it was safe. But if the investigators feel there's not a good safe discharge plan policy in place, then they certainly, as I said earlier, they would go ahead and ask the facility to show them the action plan that would fulfill the requirement of a safe discharge plan.
Right, but what if the hospital writes an action plan and the state has the ability to go without being called on? The state has the ability to say that action plan is not going to work. That's one question I have. Secondly, how would you come up with an action plan to not leave people on the street? Seems pretty easy, seems like it should never ever happen. So
Right. So any comment, Paul? What kind of action?
And actually, we do review the plans according to several requirements and criteria that must be met. And whenever and it's common for a facility to submit a plan that is not acceptable initially, and so we will respond with an unacceptable plan of correction notice, requiring the facility to submit a subsequent plan or a plan that addresses the items that we identify as not acceptable. So the eventuality is we either get an acceptable plan of correction from the facility, or we can do what's known as a directed plan of correction. If the facility is just not cooperating and not getting it, then we will actually prepare a directed plan of correction and provide that to the facility, and then they must comply with that directed plan, or additional sanctions apply.
Thank you. Any other comments? We're getting close to the time allocated for this subject. Any other comments from commissioners?
Yes, Chair, we do have a few. Commissioner
Okay.
DeServo?
Thank you, Mr. Schubert, for that presentation, and the tail end of Commissioner Bond's statements kind of was picking up where I was going. I just had a general question in regards to trying to kind of capture or frame the ballpark incidence of similar type complaints. Do you have a ballpark figure for us in our state in a given year about how many similar type potential EMTALA violations are investigated by the state? For example, would this be the first one, or is this one of a dozen, one of 100? You're just trying to frame the general scope and how many times the state does open an investigation on similar type complaints in a given year.
Yes, and so with regards to EMTALA, in general, we have less than 10 in a year. With regards to discharge planning, which maybe also include transfers or even admission requirements, I couldn't give you off the top of my head an exact number, but I know that we receive probably 50 to 100 each year of those discharge planning issues. So EMTALA much fewer, but discharge issues, we receive quite a few.
Thank you. Any other commissioner on line?
Commissioner Ralston?
You
Sorry,
on
I
mute?
was on mute. Sorry. Thanks so much. I don't want to bring up what the other commissioners have already brought up. I know this, I think we can talk all day about this unfortunate situation. I just really want to put my weight behind this discussion, and I don't want to see this die off. I think this is incredibly disconcerting. I think that there needs to be a deeper discussion about a zero tolerance policy. I know we're talking about EMTALA and what we can do to prevent, patient dumping. But I mean, what about, when you talk about penalties or sanctions, I mean, could the state really look into really enlightening us on what a zero tolerance policy would look like? I mean, there's licensure concerns, and I don't see any hospital that should be required to stay licensed when they have these types of practices, especially for patients. It's heartbreaking. Again, it's disconcerting, and I don't want to see this discussion just kind of fly off because we're going to see an investigation in a couple of months. I really, really want to stress the emphasis that these are people, these are patients, and this is a very, very serious issue that I hope that we stay on top of this discussion. So I don't have any questions. I just really want to stress the importance, I think, of us to maintain a conversation around the next steps and what really happened.
Thank you. I think we should move on because pending further report from the agency that is investigating, we will have to come back and revisit that based on their findings. So we will have a more thorough discussion at that time. We have some substance to go by that time, what actions are to be taken, and facts will be known better at that time. So if it's okay with the commissioners, we can move on and keep it
Commissioner
on.
Khan?
Yes.
Just can I get 15 seconds? This is Mason. I just, while we're on this topic, EMTALA is more of a acute care hospital. It's the highest level, but I just want to keep in mind, and as we had through the presentation, and I think Commissioner Bond and Commissioner DeSerbo, is what's the activity level on this? And we've got probably 90% of these concerns of discharging and appropriateness happen at homeless shelters, RCC, courtyard, medical homes. I think there's just got to be a way to capture that, maybe in an informal way, so we can see where people are being discharged, where it may be over their capacity, they weren't notified appropriately. Because again, those organizations don't know our lingo and what we're talking about, but they do experience it extremely heavy volumes. And they're often the shelters and the halfway houses that don't know what to do, and then come back to another emergency room. Typically your public hospitals or your not-for-profits. But again, if there's a mechanism, even if it's informal, just to data track, I think that's where Commissioner Bond and Commissioner DeSerbo were, because most people don't know how to go to the state of the website or what an EMTALA term is. So, and I agree that patient dumping is a negative slang term, but again, I try to use the words unsafe patient discharge. But I'm just trying to capture those voices out there that may not be as sophisticated in the process that we are. So sorry, Commissioner Khan, but we'll close it.
I think we should move on pending a second update at our next meeting. And hopefully they'll have full report by then, and we can debate it again in more detail. So I appreciate that. Thank you very much. Our next item on the agenda is the recommendation to support an amendment to Assembly Bill 7. Commissioner Bond has the lead on this one. Commissioner Bond, would you like to start off the discussion in your perspective?
Chair Khan, just really quickly, I'm so sorry to interrupt. We do have a LCB staff who has kindly offered to join our call and answer any questions with regard to this
They're
topic.
already, they were due at 10 o'clock.
At 10 o'clock. So it's only 9:34. Would you like
Right.
to go out?
So
of order?
it depends if we can restrict our discussion for the next 25 minutes on this subject and wrap it up, then we can go to them at 10.
Okay, thank you. I apologize.
So I think if everybody would respect the timing, because that report from LCB is very important, unless we want to take the report first and go, second with this agenda item.
I'd like to just get the issue going, if that's okay, because I have
perfect. That's
limited
fine.
time today.
Yes, so let's
And
proceed.
thank you. And I do want to just go back on the previous issue and request again, besides an update, can we please ask the state, can we have a proposal where the state comes to talk to us about what remedies could be? And to Mason's point, can we please ask for some informal data, thinking about how we would gather information about how much this has happened? I think those are two action items. I know we can't take action the same meeting, but can we get those on the agenda for the next meeting? I'd appreciate it. Then we
I
can.
think that should be fine.
Okay, thank you. On this issue of the bill that, as we all know, and everybody's been really involved in this on the commission, there's 3 bills, BDRs, that the commission's able to sponsor, and we got through a pretty robust process, I think, to get those out this time. One of the 3 is the one that Melinda Southard's talking about right now that we need to have a discussion about. That bill was written incorrectly. It was written inside a section of NRS that isn't the section that it needs to be in. That was recognized, and there was an attempt to change the language in that bill draft right before LCB's deadline for commissions to submit their 3 BDRs. This particular BDR, which is about health information and patient records, I think we all agreed on. It was one of the top bills that we all agreed to sponsor, but it was written in a way that looks like it's just directing the health information exchange to do something. So we need the bill to be amended, and Melinda has worked hard on what the remedies could be for it. And I think at this point, I just wanted to, I've been doing the legislative session for a really long time. I think it's hard when a bill gets introduced, it's incorrect. I think the opportunities we had are withdraw it, which is not a great strategy, because then we lose a whole bill and we only have 3 in that commission. So a second strategy is to introduce an amendment when the bill goes before the committee. And honestly, that's not ideal either. But I think because the bill between now and then is going to live in its incorrect form, I think that that's a frustration that we might have to work through and we might have comments about as in the commission. But I think at this point, I would support, if the commission would support and consider, that we would work on a new amendment, an amendment to the bill to try to correct the flaws that it has in it. Particularly, it doesn't talk about interoperability, and it really doesn't talk about patient access, and that was the point of the bill. So we're really trying to improve the intent of the bill around what the PPC actually approved. So that's my very short introduction of what we could do with this bill. The other option is just to try to accept amendments once the bill has a hearing. And I think that that third option is not a good option. So it seems like out of the 3 ways we could address this, the second one of an amendment is probably the cleanest at this point, but I'd welcome discussion.
So let's proceed with comments and discussion on this. Melinda, could you kindly recognize the commissioners?
Absolutely. Anyone wishing to start the discussion, please go ahead and raise your hand.
No one?
Not seeing any hands raised, Chair.
So Commissioner Bond, you suggested the second approach is, in your opinion, is among the 3 options is the better one?
Yeah, I think at this point, if we withdraw the whole bill, then I don't think we have a chance to have that bill as part of the PPC's offerings. But I do think that if we introduce an amendment, what I would propose, if we can accept this, is this an action item today?
Yes. I
Yeah.
apologize, yes.
So what I would propose is if we could approve that we will work with Melinda on an amendment with LCB to capture the full intent of the PPC's proposal to make records interoperable and to make providers help with that and to make patients have access to their medical records in whatever form they want it in, across the state.
So is there any more discussion? If not, we'll consider this as a motion if we have a second to approve this.
Chair, I do see Commissioner Van Helling's hand is raised.
Go ahead, Commissioner Van Helling.
No, I think to Commissioner Bond's point, we certainly don't want to lose an arrow in our quiver as far as having a BDR. And I think an amendment is the proper procedure to be able to pursue that. And I think it's totally doable if we're able to lobby it right and advocate for right. So I think her suggestion, I would like to make that in the form of a motion to continue our BDR on interoperability and health exchanges and with the pursuit of amending it while in session.
So do I have a second? There's a formal motion on the floor.
Dr. Khan, I don't think that this should include what Commissioner Van Hollings just said about exchanges. I think what we're trying to do is separate this interoperability issue from exchanges, and that's what got tangled in the current proposed statutory, the BDR. So I would like to, if it's possible, if you're okay with it, Commissioner Van Helling, strike the part about health information exchange that you just said and say this is about interoperability, and we'll bring back a proposed amendment.
Yeah, you're correct, Commissioner Bond. Once it came out of my mouth, I said, oh, I used the wrong term, but they go so much together sometimes. But absolutely, the word exchange, I would like to take out of my motion and just talk more about interoperability and electronic health records and information sharing and getting the hospitals and medical providers support on that. So please strike exchange. Thank you for the correction.
So then that's the current motion. Is there a second for this one?
I'll second.
Okay, any other discussion? If not, then I can call for a vote. Is anybody opposed to this motion? That's easy to do. No one? So I think then the motion carries, and thank you for that. And then we can, is the LCB here? Melinda?
I am looking. I do not see, no, they are not here yet, Chair.
Okay, so we can go to the next item, number 6. We may have to interrupt it if it's okay with the commissioners, because LCB really did a special favor to us because they were, really backed up in their work. So we might just interrupt for a brief, input from them. So the next item is item number 6. Consider appointing not more than 4 individual commissioners with Nevada legislature experience to provide individualized support via email to the PPC executive director before and during the 2023 legislative session for the 3 PPC bills. So the idea, as you might recall, that came about is how can one provide some input and support for the executive director also to reach out and via email, as it said in this case, and give their views. I had exchanged views with or rather sought input from our AG's office, and they clarified what can or cannot be done. I can let Commissioner Bond proceed, and if need be, if there's any question, is our AG's representative here?
Yes, she is on.
Okay, so she can answer any questions that we might have on the legality of approaching the subject. The other option is maybe we can ask the DAG, the AG's office, to give their input first so we can focus on what we can actually do hearing from the legal side. May I request our DAG to give us their perspective on what can or cannot be done legally?
Good morning. Good morning, Chair. Suzanne Sleva from the AG's office. With all due respect, I would prefer to hear the specific concerns, et cetera, first before I address them, just so we don't reinvent the wheel.
Okay, that's fine. Commissioner Bond, you want to proceed?
Sure, I can try. Just for the benefit of the rest of the commission, when this happened, when the AB7 situation happened, where we really didn't have a way to easily remedy it in time, it raised the issue of how do we move through the legislative session in whole, and how do we track what's going on with the 3 bills that we introduced, and how do we pay attention to what's happening with them through the commission. I think everybody knows the legislative session starts in February and it ends the first week of June. And through that time, each bill goes through a pretty complicated process. And there's a lot of input that's received from people that are legislators, but also from people that are not. And I think that it's complicated to try to anticipate what that input is without understanding the process really well. So I think the proposal was, could we have done something about this AB7 issue had we been more engaged a little earlier on? And to me, we could have. So I think this is a way, an attempt to try to make sure that we are able to participate and understand what's going on in the session without interfering with the session and without going and providing testimony about these bills, which we cannot do as commissioners. We can only go and talk about these bills as citizens. So I'm not exactly sure, and I think I'd appreciate some help from Sarah, who used to be the executive director of the commission last session and had to navigate 2 bills because we didn't have a third, and the back and forth that goes on between LCB and the legislators and the executive director. My proposal was, let's put a group of people that are the commissioners into a position where they can respond to emails that come in or respond to the commissioner with questions that come in and participate in making sure that this bill moves as smoothly as possible and provide our expertise, because some of us have it in the legislative process with those that have done it before. And the commission does have the authority vested in it through the way it was created to have subcommittees. So the idea is how to navigate this with some support for our executive director, who has not done a legislative session before, to help with that structure and that expertise, and also help field issues as they arise.
Thank you, Commissioner Bond. Susan, you want to follow up on that now?
Chair, really quickly, I'm sorry, I do see Commissioner Ralston's hands raised. Do you want to hear her first, or?
Yeah, that's fine.
Yeah, thanks so much, Commissioner Bond. I really appreciate the context and the opportunity to kind of just weigh in a little bit. And I really do think, for a matter of perspective for not only the public, but the commission, this is a new commission as well. Some of the commission members were around last legislative session, but I do think that there are a couple of things, Suzanne, that would be good to just weigh in on, in my opinion. One is that the legislature is not subjected to open meeting law. So that does create kind of a little bit of a concern, I think, when you have a public body that is subjected to open meeting law, and then you've got the legislature that is not sometimes, and we do not have the capacity to compel the legislature to do anything. These are all recommendations, and we have to be mindful of their process. What happens is, if you don't have a designated authority or a group, as you're suggesting right now, that has the ability to talk to the legislature as they're navigating their process and keeping in mind the goals of the commission, I think that that's where we need to focus on. And so my experience last legislative session is that I did not have the authority from the public body and didn't go through the process to negotiate any of the bills or to talk to the legislatures. So any time that I was representing the commission, I represented the commission based on the intent of the legislation that they had passed and the action that they took on one meeting. So that presented some challenging dynamics. And so I think going into this session, some lessons learned, and of course, what we just heard with the last bill draft needing to be reworked, sounds like pretty significantly, that there is going to be some other challenges. So I would like to hear your thoughts on, the open meeting law and the public body. I think that's number one. Number two, the other issue that I think arises is who has the authority to speak on behalf of the Patient Protection Commission. I face that question pretty more often than I think I should have. In my experience is that, you have other members who have lobbyists, members who have discussions, and that's all a part of the legislative process. However, I do think that the commission should be aware and the public should be aware of who is given the authority to speak on behalf of the commission. And if some individual does want to speak because they may not necessarily agree with some of the changes or modifications, I think they do have the ability to speak upon themselves and go through the legislative process. I just think that they need to be reminded that they are speaking individually or on behalf of their group. It's really about disclosures and disclosing conflicts of interest and really making sure that there is only one designated voice or the person is accurately representing themselves through the legislative process. So those are the two biggest things that are glaring for me that I think we should talk about and give direction to our executive director and talk about and defining the goals and the scopes of this potential subcommittee. So if I've missed anything, Babette or others, Mason, Yarleni, I'm looking at everyone who is also a part of the commission last legislative session. If there's anything that I missed, by all means, I am happy to address it, but these are just my suggestions.
That was helpful. Thank you.
And if I may, this is Suzanne Sleva from the AG's office. Talking about the, I guess it was issue number 2, but as far as who may speak on behalf of the PPC during legislative session, et cetera. What needs to be done is if there is a particular commissioner who would like to speak on behalf of the PPC during the session on a particular bill, particular issue. This is something that needs to be addressed in an open meeting and voted upon. For instance, if the PPC has a bill that says that Suzanne Sleva is not allowed to ride a bicycle on a public street because she should not be able to, and Commissioner Bond would like to speak to that regarding the issues with that bill in the legislature. What would need to happen is during a meeting that had been agendized, noticed, etc., all the open meeting law machinations, there would need to be a vote from the PPC members to say that that Commissioner Bond does have the authority from the PPC to speak on that particular bill. And that can be done for the different bills or possibly different issues. And as Commissioner Ralston said, there may be other members of the commission who have differing opinions, interests, input apart from that officially designated to the representative of the PPC, and they can speak on those issues, but simply they need to make sure that they are speaking in a different capacity as a private citizen or as an employee of such and such or whatever, but they are not speaking on behalf of the PPC or necessarily expressing what has been decided at the PPC.
Yes. And so, and I don't mean to go out of order. I see that Commissioner Bond has her hand up, but I wanted to throw out another a question about what you're saying specifically is I think that we do have a new opportunity this legislative session to maybe do something a little bit differently that works better, that is a little bit more functional. Would this subcommittee, if given the authority by the commission, have the ability to then be given the authority to have a discussion with the legislature and negotiate on behalf of the Patient Protection Commission to make sure that the intent of the bill lines up with the commission's goals? And so if this commission were to vote on that actionable item today with that scope, is that enough of an action item with this public body and the legislature for then the commission to understand that the subcommittee could then do that on behalf of the commission with the pretext that they would report back to the full body? Is that something that the subcommittee would have the authority to do if it was given the direction via action today?
Today, let me double check the agenda. I don't know that they'd be able to do that today.
Or even in the future, if it's properly agendized, however you'd like to agendize it. I mean, I think that the agenda does say define goals, activities, and scope. So I'm just saying within that confines of defining scope, would that be a possibility? And I'm not saying that maybe I'm jumping ahead of myself. Sorry, commissioners, but I just wanted to know for context what the options are legally.
I'm thinking that it could be what would probably be if indeed we were going that route. I think what would need to be done is if indeed there is a subcommittee formed and if the subcommittee is meeting, conferring, etc., that of course would have to be agendized, noticed, all according to the open meeting law. And in reference to meeting with and negotiating with the legislature, etc., I'm thinking the best way to do that, if there's a lot of ifs here, so I've got to follow the bouncing ball. But if there is a subcommittee, if the subcommittee wishes to be able to do those things, such as negotiate with, discuss, etc., with the legislature, I'm thinking that one member of the subcommittee should be designated by that subcommittee as the point person for that type of thing. At which point, then the subcommittee would need to present the recommendation to the full PPC. That would need to be agendized as an action item, and the PPC would need to vote on whether to accept that recommendation and authorize the designee of the subcommittee.
So this is a possible action item today.
It is.
It says for possible action, recommendation, and possible approval from commissioners. Sorry, just where am I? The other one. Appointing not more than 4 individual commissioners with Nevada legislature experience to provide that. It says for possible action.
That you are correct, Chair Khan. The only thing is, and I had discussed this with the executive director and with my supervisor, Julie Slaybaugh, last week, that it's my understanding that what was being discussed was not so much a subcommittee, but simply, no more than 4 of the commissioners providing support to the executive director, that this group of commissioners was not going to be meeting. So it wouldn't necessarily be a subcommittee. If a subcommittee is something that the PPC wants, that is something that could certainly be formed, but I think there would need to be meetings that were noticed and agendized, etc. So that adds a whole other layer of work.
Yeah, so let me ask very specific question.
Yes.
We have said in this public agenda, consider appointing not more than 4 individual commissioners with Nevada legislature experience to provide individualized support via email to the PPC executive director before and during the 2023 legislative session for the 3 PPC bills. And it would define goal activities, short of, as you are suggesting, of creating a formal committee. What we are asking in the agenda is the commission designate 4 commissioners as individuals to potentially represent or assist with, not represent, assist the executive director to follow up on the bill as it is moving through the legislative process. What you are suggesting is it come back to the full commission every time. The way that will work is we meet once a month. In the meantime, the bill may have even passed. I mean, things move in the legislature either very slowly or very rapidly.
Understood. And like I said, that is an issue that comes about when we're talking about having a formal subcommittee. Now, the discussions I've had that I had previously, and we had some emails to this effect, is that the individual commissioners who are providing support to the executive director, that does not necessarily need to be a subcommittee. In fact, it would probably be better if it weren't, just for time efficiency and things like that. The designation of those commissioners would need to take place in an open meeting such as this one, and we do have that agendized. If there is no intent of forming a subcommittee, then the individual commissioners would not communicate with one another, but would only respond to and communicate with the executive director.
Okay, so Commissioner Bond, does that fulfill the original intent of this communication?
Well, I didn't respond after I got that email saying that the way that it could work without us running into trouble with the open meeting law is just to communicate when the executive director reaches out to us on email and not talk to each other. And I don't think that's everything we need, but what I would like to do today, if possible, is get as far as we can in the agenda, which is that we can appoint 4 people to support the legislative process with our executive director. Can we get that done today? But then I think that we need some follow-up conversations about what is the scope of that, because a one-way email from Melinda that generates us being able to send a one-way email to her is also probably not the extent to which we need to provide support. But I think we should, and I really appreciate Sarah, I'm going to call you Commissioner C. Ralston because your name's too hard. I really appreciate her input today too, which I had not provided or heard before. So I think the issue of who leads inside the building is also something we should try to discuss. But for today, the very least we can do is provide email when Melinda asks, with 4 commissioners appointed to do that. Let's do that. And then in the next few weeks, can we talk about what else our scope could entail and bring it back?
Let's hold that thought for a second, if it's okay with all the commissioners. I have no problem with that personally, to designating 4 people to be able to communicate in that respect. But we have the LCB people already here. Can we have them brief us, and then we can make a decision for possible action on what was just suggested?
Sure.
Do we have LCB people, Melinda?
Chair Khan, can I act? I'm so sorry. I don't want to take it out of order, but something else just occurred to me that I really think would be good for our discussion about this process. If you don't mind, will you let me indulge for just a couple minutes?
Yeah, okay.
So one thing that I'd like to bring up, and again, for our deputy administrator or attorney general, our DAG, my question is that I think the whole context of making sure that we're compliant with the open meeting law is by and large to make sure that the public is informed and that they're a part of the process. They understand that the discussions are being held, and so that no one is feeling like things are happening without the ability to provide input. Would we be able to have a discussion about the commission and when you do designate 4 members or 3 members or 2, however many, as long as we have a discussion and the public is aware that this group exists that is meant to advise our executive director through navigating the legislative process, why would there be any constraints with having those commissioners talk to each other? Because otherwise it really is counterproductive. So could we have a discussion in which publicly, even if you put it on the next agenda so that you give the public an opportunity to opine if they have an opinion and they want to express any concerns about it, could we have a scenario in which a designated advisory group is created? So it's not necessarily a subcommittee that is then subjected to open meeting law, but an advisory group that is created for advising the executive director during the legislature on the commission's bill drafts, and then subsequently authorizing the executive director to negotiate the bills on behalf of the legislature, something like that. Because what I do think is a problem is if there is a formal subcommittee created that is subjected to open meeting law, and then the commissioners can't talk to each other, that actually creates, I think, is more counterproductive than being productive, because the whole process is rapidly, can we communicate amongst these people through a very, very fast legislative process, right? We never know if a bill is going to be heard. It could be heard within an hour's notice, or we could be given 3 hours notice, or we could have a chairperson who decides that they don't want to have any communication, and then we have to just navigate the public process. And so there's a lot of different dynamics, and I think that we don't want to put ourselves in a situation where we're more constricted, because I think it sounds like it'll be counterproductive. So I would like to propose a discussion of creating an advisory group to the executive director, and then potentially allowing the executive director to then work with the legislature and or negotiate the bills accordingly, something like that. Because I certainly don't want to restrict the commissioners from having discussions.
For our LCB, Susan, could you please hold your thought? Let's listen to the LCB and everybody give thought on what was just said, and then we can get back to it in a few minutes. Go ahead, Melinda, let's have the LCB.
Thank you, Chair. And I just wanted to say thank you to Brian Fernley for being here today with us from the Legislative Council Bureau. The commissioners had discussed Assembly Bill 7 and potentially drafting a amendment to correlate to the commission's full intent of the bill to include, not only patient access, but also the interoperability component of electronic health records. And
remove its
yes,
being tangled with the exchange. We just got to keep saying that to make sure we all understand exactly what we're trying to do. Sorry to interrupt.
Yes, thank you, Commissioner Bond. Very important distinction. And so we invited you here today to, provide any perspective on that proposal to do the amendment. And we really appreciate you, working with me and the commission in developing that amendment. And I just wanted to note if there were any specific questions from the commission for Mr. Fernley, please feel free to address at this time.
Go ahead, please.
Thank you. This is Brian Fernley, Legislative Counsel with the Legal Division of the Legislative Council Bureau. I was asked to be here to answer questions about AB 7. Assembly Bill 7 relates to the electronic health records. It was pre-filed as required by statute on November 18th. So that is how it became AB 7. It is currently going to be referred to the Assembly Committee on Health and Human Services for consideration. We did receive the proposed amendment for AB 7, and we will provide that to the committee chair and committee staff so that it can be presented and discussed when the bill is heard during session.
We haven't seen that. I'm sorry, I don't mean to interrupt, but I'm concerned that now I've never heard that. So I think that we want to be involved in actually blessing the amendment before it becomes an amendment, because we don't want this to happen again.
A quick,
Well, what I can say, the LCB legal has not prepared an amendment. We would forward the document submitted to us to the chair and staff of Assembly Health and Human Services. We are happy to, we are still in the process of evaluating and looking at that amendment. And if we have any questions or concerns, we will definitely reach out to your executive director and address those. But we have not prepared any document. We were just forwarding the document that was provided to us to the chair.
Okay, well, that was written by me, and that was written on a really, really stringent timeline where the PPC was meeting that day, and the amendment, any changes to the BDR were due that day. And so I wrote that just to make sure we got the main issues into the bill that were flagged really by the group as omissions. But that shouldn't be the genesis of a new amendment until we all have a chance to, in my opinion. I mean, I would defer to, the chair and Melinda and the group, but we should see that before it becomes an amendment in full and make sure that we're comfortable with the language, because this will just happen again.
Yeah, and we will definitely do that.
You will do what?
We will take what was provided to us. We will prepare a mock-up and let you see it. But I mean, probably even before session starts.
That would be great. And then we have a chance to correct the mock-up. We can spend a little more time on the language. Okay.
Yes.
So I think in the interest of timing and the legislature starting pretty soon, I would like to have this an agenda item to address this, Melinda, at our next meeting, so we can collectively agree to proceed with the language of the amendment and then send it to the LCB. Is that okay with the other commissioners?
Yes, with me.
Okay. All right. Any other comments on this or questions for LCB?
Are we going to ask LCB about this issue of the committee work as long as they're here? Or is that just a DAG issue?
We can take perspective of LCB if they were listening on to our discussion earlier. What is their perspective?
Yes, and I think I would need to defer to your Deputy Attorney General, as that would be your legal advisor on this issue. So any sort of legal advice or legal opinion that you would need should come from the Commission's attorney, who is your Deputy Attorney General.
Thank you.
Yeah.
All right. Any other questions for our LCB legal? None, Melinda?
seeing none, Chair.
Okay, thank you, really. Thank you very much. I know you had to work your schedule around to accommodate us. I really personally appreciate that. I'm sure the commissioners appreciate you coming in on short notice.
No problem. Thank you. And we will get the a mock-up of the proposed amendment to your executive director.
Thank you very much.
Thank you.
Thank you. Take care.
Thank
All
you.
right, let's come back to our discussion where we left. You want to pick it up from there, either Sarah or to propose a language?
And this is Suzanne's.
Can I just say before that, I'm sorry, we're being so out of order today, all of us, well, some of us. I think that conversation just really exemplifies what's going to happen, right? There has to be some way to quickly address, because LCB is going to interpret things the way that they're going to interpret things. And we don't know if that's, I mean, what he just said of sending that language all the way to Assembly Health and the chair is like, that would be the next thing we would have to fix. So this is why I think that we need some way to engage in the process. And it's not realistic to do it in once a month in a meeting, because things are changing and will start to change quickly. So this is exactly the issue we're trying to figure out how to support Melinda in.
So, Susan, the language that Commissioner Ralston mentioned earlier of designating commissioners, the committee creation creates a problem of open meeting. Is that a problem?
Yes. Yes, Chair, it is. Anytime you have commissioners conferring, particularly commissioners that are designated by the PPC to address and explore a particular issue, anytime you have them communicating with one another, that needs to be noticed, agendized, and follow the open meeting law. Whether it's called a subcommittee, a work group, an advisory group, the designation doesn't really matter. What matters is that the commissioners are conferring and discussing PPC business. I understand completely the time constraint issues and that things can happen fast and furious during the legislative session, but that is just the way that the open meeting law is written. So if you've got commissioners communicating with each other and not simply with the executive director, there will need to be, it is a public body and it will need to follow the open meeting law.
So I hear you loud and clear, but the question that these designated 3 or 4 commissioners, if they communicate their views with the executive director back and forth as an individual, not as a group with each other, that is appropriate.
Yes, that would not be a subcommittee work group or anything. That would simply be designated commissioners communicating with the executive director. That would not require the open, that would not necessitate, excuse me, all of the open meeting law requirements. What triggers the open meeting law requirements is when the commissioners communicate with each other.
Okay, got it. Any questions on that, Commissioner Bond or Commissioner Alston?
Yeah, I'm sorry. I don't mean to be the problem commissioner when it comes to that. Just I do have a different perspective on the compliance of open meeting law based on just my general knowledge and advice that I had been given prior. And I believe what you're talking about is just like the issue of potential serial communication in order for commissioners to deliberate towards making a decision on any matter in which the public should be properly noticed. However, I think that's only applicable to if it's like a quorum, right? I mean, if we're a smaller amount, and then the public is already aware that 3 members or 4 members are going to be communicating, and not about just commission, like a blanket discussion about commission priorities. I mean, it's specifically that you designate X amount of commissioners under quorum to have a discussion about the bill drafts and making sure it stays in alignment with the commission's intent on the action that they took on X date and advising the executive director. I just don't see how that is out of compliance with open meeting law, because they were given a direction. The public was aware that they're going to have this communication on a very specific topic, and that they are going to be sending their comments to the executive director, who then will be reporting back to the full body on these discussions. So the public is aware of the discussions that are anticipated, expected, they're gonna happen, and then they will be reported back to the full body and to the public. And so I don't see how that is out of compliance with open meeting law. I do see if it was raised concerns, if it was just a blanket discussion about all PPC, but if we're making it a little bit more narrow, how do we not get the green light to have that as an option? So that's where I'm struggling.
Go ahead. You want to comment, Susan, or Bobette?
Yes,
Go ahead.
Yeah. Where we get in trouble with the open meeting law is that if there is not a meeting of this group, that how would the public know that they were meeting, what they would discuss, and the public wouldn't be able to participate?
We predetermined that. That's what I'm saying, is that the public is aware that the group of commissioners will be meeting throughout the legislative process from this forward on up until the end of session to discuss the navigation of the 3 commission bill drafts with the executive director.
That-
My thought is actually in line with Commissioner Olson. And the reason is, as Commissioner Olson just pointed out, in my way of thinking, and I'm not a lawyer, is the commission designated 3 or 4 people with a specific item of pursuing the legislative process as it proceeds through the legislature. They are not discussing new subjects. They are not discussing anything differently. They're not discussing change in the language. They may be following through. If a change in language is to be just hypothetically considered, it have to come to the full commission. And it may be a moot point anyway, as Elsevier told us, once for example, this amendment goes through, once the process starts, you cannot change anyway. It's during the process giving technical or language advice, not making decisions or advising the executive director to change the subject or deliberate on a separate subject. That's the way I'm looking at it.
And I understand your point, but legally, that is something that what you've just described would be something that would be considered a subcommittee or a work group of a public body. Therefore, it would qualify as a public body and need to follow the open meeting law.
No, but
The only way that I think that the open meeting law would not apply to this process would be if it, as we discussed previously, if the individual commissioners that had been designated by the PPC to provide support to the executive director communicated with the executive director and only the executive director individually. That's the only way I see that the open meeting law would not apply. Otherwise, I think it would, like I said, we could call it whatever, we could give it whatever designation we wanted. I still think it would qualify as a subcommittee or a work group.
any other comments in the bond or?
I have one more. I mean, this is all frustrating because this really, I think what it means is it's probably not appropriate for commissions to have bill drafts because you can't govern them once it starts. And so I'm real frustrated about how we make sure we get what we thought we wanted in general. But specifically to what you just said, Dag, and I really appreciate the expertise. We definitely need it. I appreciate everything that Sarah's trying to share about her past experience. It's not realistic to try to do this in a full PPC. So if we are, can we formally request that our executive director send these 4, every communication that she receives, it related to these bills from LCB, from a legislator, from someone that's providing testimony, from a protagonist, from an antagonist, that we see all that. Can we request that she send that to us? Because that's the only way we're going to know to reach out to her. Telling us that we can have a group of 4 people, but all we can do is a one-way communication to our executive director doesn't in any way let us move through this bill.
And I do understand that. And I do think that it would be acceptable for the executive director to maybe send out a list of the communication she's received, etc. Like she does so beautifully with the issues that we have through the PPC now. She sends it out to the chair and the commissioners so that everybody knows what is going on. But like I said, where we get into needing to follow the open meeting law is when the commissioners communicate with one another.
Can I just say it again? Can we request as a commission today that the executive director provide all communications about these BDRs to the commission or to a subset of the commission?
Yes, I think so.
As they happen, because that's the only way this is going to get navigated.
And number 2, the commissioners as individuals can communicate back to the director what they think in that individual opinion needs to happen with whatever is happening in the legislature.
Yes, as long as it is done individually, yes.
Does that answer the question, Commissioner Bond?
Well, it gets us a little farther down the road for what we can accomplish today and the time we have. So I think what I'd like to return to is can we proceed with this and try to identify commissioners that would be interested in this role and that have the expertise for it, keep it small so that we can move fast. And can we do that today? And then I think that we would like to review the open meeting law. I want to just do that on my own. Maybe we can have this on the agenda next time for whether there's any clarifications needed, but we could get that far today with the appointment if the commission's willing.
Okay, I really would appreciate if we can move along, and this is the best we can come up with today based on the information we have legally. So I think what Commissioner Bond just said, if somebody, this is a possible action item, if somebody can propose that we have this 3 people or 4 people, then we would need some volunteers. But I think we need to first vote that we agree, if we do, on creating a not a committee, but designating 3 or 4 people to have this communication with the executive director individually. Then we can have volunteers to be serving on that.
So I'd like to propose that motion, that we
Okay.
create a small group, 3 or 4 people that are willing to volunteer some of their time as commissioners to support the legislative process and our 3 BDRs and the executive director.
Is there a second?
I see that Commissioner McAllister's hand is raised.
Okay.
Hi, thanks. So I would be concerned that if Melinda's sending anything out to any commissioner, I want to see a copy, whether or not I'm part of some small group. I may not respond, but I at least want to see it.
Any other comments from commissioners? First of all, I think to get back to our procedure, let's have a second on this motion, then we can have a discussion and a vote. Is there a second for this motion?
This is Yarleni Roadugan. I second the motion.
Okay, so we have a motion on the floor. So now we can have further discussion. We already have one opinion from one of our commissioners. Any other comments from other commissioners in support of this motion or against the motion? So we can then take a vote. Any other commissioners raising their hand, Melinda?
Seeing none, Chair.
Okay, so I think then we should call for a vote on the motion. Kindly raise your hand, all those in support of this motion as put forward. Melinda, are you watching any hands come up or down?
I am watching, Chair. Just give it a second.
I'm sorry, was that in favor or opposed?
In
Those
favor,
in
right?
favor
We're
of
trying to
this
get to in favor.
Yes.
Okay, so in favor, Chair, do you want me to call out the commissioners' hands I see raised for in favor?
Yes, please.
Okay, so in favor, I have Commissioner Bond, Commissioner Van Helling, Commissioner Ralston, Commissioner Grady, Commissioner Roa-Dugan, Commissioner Tyler Garner, Vice Chair Rubelid, and that's all at this time.
And I support this motion also.
Chair Khan.
So does this motion carry based on our numbers, correct?
Based on numbers, yes.
Okay, so the motion carries, so we will proceed with that. Now the question is who is going to volunteer? As was mentioned earlier, ideally, somebody who has experience with the legislative process would be preferable, but obviously we cannot mandate that. Any volunteers? I'm sure Commissioner Bond would volunteer.
Yes.
Okay, any other? I think we should have at least 3 people on this group. Do we have a couple more people willing to volunteer? All it involves is an email received by the executive director, and if you have any comments from a legislative experience, you can share it with her via email. No meetings.
Yes.
May I ask, Commissioner Ralston would strongly consider serving on that committee, even if it's just the benefit of having some of that institutional knowledge or context.
Yeah, we
like-
saw her hand up.
I like. Commissioner
Yeah,
Ross,
I will, I'd be happy to participate and help our executive director in any way.
okay, is there anybody else? We need at least 3 people ideally.
So I do see Commissioner Rojigan's hand is raised.
Okay, so we have 3
No,
people.
I apologize. That was old. Sorry.
Okay.
Okay, anybody else? If not, we may end up with just 2 people. Okay, I guess we'll have 2 people on this group.
Can we get a commitment from at least one other person to do it for balance?
Yeah, I know, you're probably more persuasive than I. No, I agree. Ideally, we need 3 people.
I do see Commissioner Van Halling's hand is raised.
Okay, fantastic. Okay, so we have 3 people, and that would be, I think, very helpful for our executive director and for the process to get what we ideally was the intent on these. All right, I think we should wrap up the subject. We have deliberated a lot, and I know Commissioner Bond has to leave at 11. You just be half an hour more of her time. So we can move on to the next item, 7 for possible action. Recommendation and possible approval from Commission for the final January 1 PPC report to the governor and legislature as required by NRS 439.918.2. So Melinda, you want to take it on?
Yes, thank you, Chair. All right, so Commissioners, as you can see here, NRS 439.918, Section 2 requires a report from the Commission every 6 months to the governor and the director of the Legislative Council Bureau for transmittal to either the next regular session of the legislature or the Joint Interim Standing Committee on Health and Human Services. So this specific requirement for the report are that it must include, number 1, a description of the meetings of the commission and the activities of the commission during the immediately preceding 6 months, a description of any issues identified as negatively impacting the quality, accessibility, or affordability of healthcare in the state, and any recommendations for legislation, regulations, or other policy changes, or other changes to policy or budgets to address those issues. To meet this requirement and in due diligence to public process, I've drafted the January 1 report you all should have in your meeting materials today, and have previously requested review and feedback from the Commission on the statutorily required report. I'm happy to note that I've not received any opposition on anything contained in the report and have only a few minor edits that were requested. I understand this might be a new process of sharing this particular report publicly, both with the Commission and during our meeting today, and would like to solicit approval of the Commission to submit this report as required, pending, of course, discussion and comment from the Commission today. My intent in doing this is that I did not want to submit a report on behalf of the Commission that the Commission did not have a chance to review or provide any feedback, continuing in my commitment to you all of transparency. I'd like to now open this item for discussion and happy to address any questions or comments you all may have.
If I may ask the Commissioner, have they had a chance to look at it?
I have not. I'm sorry. I'm in full disclosure. I think I really appreciate that you as executive director are giving us a chance to, and I'm sorry that I haven't gotten through it. And thank you for asking, Chair.
So no problem. So those who have had a chance to review it, any questions, issues, or changes that you want made, kindly let us know now so that we can proceed and have the executive director go ahead. Do you see any hands raised, Melinda?
I do not. Oh, yes, I do see Vice Chair Rubelit.
I just wanted to note that I have reviewed it and I think it looks great and I really appreciate your hard work on it. So thanks, Melinda.
I do have a question about the recommendation for staff. I mean, how would that turn into staff? Because you're asking for 3 people to work on the mail bank project?
Sure. Thanks, Commissioner Bond. So I had requested 2 staff to assist with the Peterson Millbank project and, the continuation of the healthcare cost growth benchmark, because that is such a comprehensive project. And, with the hopefully the movement of our bill through legislative session to the hopeful approval, we would need the additional support in, developing those annual public meetings, the annual public reporting, and communication with stakeholders throughout the year on the process itself.
So may I just ask then, I'm sorry to follow myself up here without permission, but if we're approving this, if this is an action item for us to approve, by you saying you're requesting 2 staff to be added to the PPC work, are we approving that we believe that we should support these 2 staff, or are we just approving that? What are we approving?
It would be a recommendation. I'd put that in there as a request for the DHHS Patient Protection Commission budget. It's a small budget with a small staff. Right now, it's just me and our policy analyst, Kylie. We do have an administrative assistant who has not yet been hired. That does belong to the PPC staff, but a staff is 3 of 3 is pretty minimal to handle the duties of the commission as well as the healthcare cost growth benchmark project itself. And I did go off of other states' organizational charts for their healthcare cost growth benchmarks to kind of get an idea. And even so, with the addition of 2 more staff to support the work of the cost growth benchmark, it is still under the minimum amount of staff that other states are using for this particular project.
So how will that intersect with what's going to happen in the legislative session, where the BDR we have to codify the growth benchmark program will come back with fiscal notes of how much it will cost to support that? How does this request line up with what's going to come out of the fiscal notes that are attached to the BDR?
Sure, great question, Commissioner Bond. So it is my understanding that this request is in an agency budget request rather than a request that's tied directly to the bill for the cost growth benchmark. So it's a separate and aligned request.
Okay, any other comments before we let the director proceed with submitting the report?
I did want to note Vice Chair Rubalid's hand is up, as well as Commissioner McAllister.
Okay. Please go ahead.
That was old, sorry.
I guess I just have a procedural question, Melinda. I sent in my comments by writing and you acknowledged them and sent them out. I don't have to verbalize anything here, right? They're already incorporated in?
Correct. Those are already incorporated in the draft. Thank you.
All right. Thank you very much. Great work.
Thanks.
Okay, thank you. If there are no other comments, then this will consider this director to proceed with the submission.
I do see Commissioner Ralston's hand raised.
Okay.
Yeah. Thank you. I just wanted to say, I think this report's great, and it is, meant for recommendation. I think it's important that the administration receive your recommendations, and there is a due process to implement any of your recommendations. So I know Commissioner Bond had inquired about the other staff members. So, but I think that you're in a situation, if you don't ask, you may not get it. And it does take a lot of work to navigate all of the responsibilities of the commission. So if anything, my only recommendation is that you didn't ask for enough. But good work.
All right. Thank you, Commissioner Olson. So I think we'll sum it up. So Melinda, you may proceed with your due diligence on this one. So the next item on the agenda is for possible action also. Recommendation and possible approval from the Commission for final 2022 inaugural patient health records plan as required by NRS 439.918.1. Melinda, you want to move forward with this?
Yes, thank you, Chair. So as noted here, NRS 439-918, Section 1, Paragraph C requires the commission to develop, submit to the Director of the Department of Health and Human Services, and annually update a plan to, number 1, increase access by patients to their medical records, and number 2, provide for the interoperability of medical records between providers of healthcare. In addition, Paragraph D requires the commission to make recommendations to the DHHS Director and the legislature concerning the analysis and use of data to improve access to and the quality of healthcare in the state, including without limitation, using data to establish priorities for addressing healthcare needs and ensuring that data concerning healthcare in the state is publicly available and transparent. To meet these requirements, our small DHHS PPC team has developed a first draft baseline of the PPC Patient Health Records Plan found in your meeting materials for today. It is ideal for the commission to approve a baseline iteration of the statutorily required plan prior to year's end, with the understanding that this plan will be reviewed and updated annually by the commission with a more formal and prolonged solicitation for public comment on this plan well in advance of each annual plan renewal date in December. In the commission's due diligence and transparency to the public, this plan was not only solicited previously for feedback from the commission, but also solicited for public feedback in advance of today's meeting. Being the inaugural version of this plan, we ask the commission and the public to please feel free to constructively criticize, edit, comment, etc., so that the commission can really mold this plan into a helpful resource for the community while also meeting the statutory requirement. I am happy to say we've received no formal opposition on this drafted plan to date. I also want to apologize to the commission and the public that there was a very short window requested for review and comment. And this was my fault for not appropriately scheduling a more adequate public comment period for this plan well in advance. However, lesson learned. So public comment on this plan will be accepted throughout the year for consideration for inclusion in the 2023 plan update. And it is my goal to more formally and widely solicit public comment on the final draft of each plan update not later than October 1st annually. So my intent today is to solicit approval of the commission to submit this plan to the director as required after considering discussion from the commission, of course. I would now like to open this item for discussion and happy to address any questions or comments you all may have. And I'm also going to share my screen to navigate to the areas of provided feedback in the document. So while I'm in that transition, please feel free to open with any questions or comments.
Please proceed.
I think, oh, I'm sorry. Let me raise my hand.
Commissioner Bond.
Sorry. I appreciate you getting this far. I think there's just a ton of information in here, and we and I did get through this one. So luckily the other one was short. I think that we're mixing up the interoperability and patient record stuff with all of the other work being done on things like prior authorization and, what the Nevada Medical Association's, requirements are for record retention. So I wonder if there's a way to streamline this. And I don't know the timeline for when you feel like you have to get this submitted, but I do think it needs another, I do think it needs another level of review and separating some of this out. There's a lot here, and it's not all related to interoperability and patient access.
Thanks, Commissioner Bond. I appreciate that. Before I go into this review, I do see Vice Chair Rubelit's hands raised.
Yeah, I just wanted to add that the patient access and interoperability rule contains things that are in this report. And so that's the connection there at the federal level. So it's not just about interoperability, it's about information sharing. There's a lot of extra requirements within the federal regulation that what Melinda has included here.
Yeah, thanks, Vice Chair. I did want to clarify that the text that you see in the plan that is in that burnt orange color is all of the proposed language from CMS in their December proposed rule update. So did want to include that in here as the proposal of being like, the cutting edge new stuff.
Honestly, I really think that should be taken out until it's passed, because I think it's confusing. It hasn't gone through final review. It might change. There's things in there that are somewhat controversial. So is there a reason that, and I don't care a lot, but it is confusing to say, here's what CMS is trying to do when it hasn't happened yet versus what we already have to do. I don't know how other commissioners feel, but it's a little confusing.
Understandable.
Any other comments? You see any, Melinda?
I am not, Chair. So if that is the decision of the commission, would you like for us to remove all of the burnt orange text that is currently in the document? Because it is not final yet.
And could it be referenced and submitted as a reference material?
It could be referenced for sure.
Any objections to that from anybody else?
I think I would just recommend that maybe we pare it down and just have like a link to the proposed rule, just so that for awareness. And if someone wants to do a deep dive, they can go look at the rule themselves.
Yeah. And I do think that we shouldn't change the NRS statute to say what the Nevada State Medical Association says instead. I think we should stick with NRS. Melinda, I can't see what you've got highlighted on the screen if that's what you were trying to have discussion about, but I caught that too, that, that's not statute in Nevada, and there is statute in Nevada.
Correct. And this language that is on the Nevada State Requirements section comes directly from the Nevada State Medical Association website as well, referencing the NRS. So I agree that it's appropriate to keep it as is unless there are any other comments from the commission. Okay, I'm going to move down to the next set of comments. So this is on section 4 for the recommendations. We received comment from the Nevada State Medical Association that while this section is related in statute, being, this section was meant to address paragraph D that I had referenced before, that the recommendations to the DHHS director and the legislature should be contained in a separate document to those entities rather than in the patient health records plan. And then additionally, we received comment from the Nevada Association of Health Plans along those similar lines that the two topics of the healthcare cost growth benchmark and patient access to records and interoperability do not naturally dovetail. And the NVHP is recommending the plan to focus on patient data access and protection. So open to your comments there.
No other comments?
I think it's the same sort of thing as like what's really should be contained in this document, what should be reference material, what should be held till it's approved. And it is your inaugural voyage, and I really appreciate it, but I'm not sure we're quite there. When does it have to be submitted?
So good question, because there is no deadline in statute, but this was a new requirement that was brought about in the 2021 legislative session through AB 348. And so I thought it would be helpful if we could get our inaugural version approved prior to year's end, just to be, timely in our completions. But obviously I do not want to submit a document that is, haphazard, and I want the commission to be presented in the best light possible.
Anybody else has any comment moving forward? If not, Melinda, you may proceed.
Sure. So Chair, if I could just ask a clarifying question of the commission, is there any opposition to removing this section and having that included in a separate document?
Please raise your hands if there is any opposition.
I think what I would like is another, since there's no deadline on this and it's the first pass, I would like to just propose that we give the commissioners, one more meeting to get through this and provide more substantive content and separate the sections out in their best effort and see if we can get to something that nobody has concerns about. Is that possible?
I have no problem personally, unless other commissions have a problem with that.
So is there any opposition to holding the for possible action on this plan to the January meeting? Please raise your hand if you're in opposition. I don't see any hands raised.
Okay, all right. So Melinda, that answers your question on this report. So we'll bring it up at the next meeting on the agenda.
And so everybody should get their comments to you in writing before that, right?
Yes, please.
Okay, thank you.
Thank you.
Thank you.
The next item on the agenda is item number 9, discussion of Nevada's healthcare costs in context relative to other states. So we have Michael Bailiff.
Yes, so thank you, Chair. So per Commissioner request, we've invited Bailiff Health here today to present data and hold a discussion regarding Nevada's healthcare costs in context relative to other states nationally. So I'm happy to welcome Michael Bailiff to lead the presentation and discussion for you all.
Thank you, Melinda and commissioners. So for context, you've heard in public comment from Mr. Kelly the last couple of meetings that healthcare spending in Nevada is low. The purpose of this brief presentation is to verify and then contextualize this information and to demonstrate that despite comparatively lower per capita healthcare spending, healthcare affordability is a serious concern for Nevadans based on multiple data points. So that's the information I want to share. Next slide, please. So you've heard it report during public comment that healthcare spending is lower. It's important to contextualize it in income, and income in Nevada is also lower. So when we adjust for median income, the state's per capita healthcare spending moves from 3rd lowest to 10th lowest. So still lower than most states. And for healthcare spending, we're using data from the Office of the Actuary at CMS. And you'll see the sources for all of my information footnoted. So I'm verifying what you've heard in public comment. That is that healthcare spending is lower in Nevada. And even when we adjust for the fact that household income is lower in Nevada, it still is relatively low. Next slide, please. So whoops, we've gone way too far. Back further, please. Back further. Okay, right here. So we also looked at change in spending in the commercial market, because that's where affordability is the greatest concern. And we've looked at it over the last 20 years. And what we found is that healthcare spending per enrollee per year is growing annually at 4.4%. Median household income in the state grew 1.7%. So obviously you can do the simple math. That's more than twice the rate of income growth. And that means that more and more of take-home income each year is going to pay for healthcare bills. It's not going to pay for education or housing or other social goods. Next slide, please. When we look at affordability in terms of what workers are paying, workers pay for healthcare 2 ways. They pay for contributions to premiums as payroll deductions, and they also pay through cost sharing at point of service. So we looked at 2 different trends. This is data from the Commonwealth Fund. The first is worker contributions. They grew in Nevada between 2015 and 2020 at double the national rate, or actually more than double the national rate, for both single and family coverage. That's contributions. And we saw the same thing in terms of deductibles. So when do deductibles grow? They grow when employers are trying to manage premium growth. And so employers will typically expand product offerings to have larger deductibles, and consumers or workers who are trying to manage their payroll contributions will often pick plans with larger deductibles to keep the contributions manageable. So we can see in both ways, Nevada workers have been spending a lot more and spending a lot more relative to workers in other states. So again, growth in healthcare spending, this time defined in terms of premium contributions and deductibles, is taking up more and more of take-home pay.
And can I just say, because I work on the other side of this with can I just clarify and make sure I understand?
Sure.
This doesn't really show, but there's an inference here that when employers end up increasing their deductibles and co-insurance in order to make premiums more affordable, they're not doing it to have their trend go down. They don't then have lower insurance rates that they're covering. The insurance rates
Right.
continue to go up. So this is just one of their ways of trying to live with that, right? Trying to stay in the health insurance business. It's not so that they can ratchet down how much they pay for healthcare. It's just so that they don't pay a lot more, or proportionally way more, because it's
Right.
all just trying to adjust a trend.
Right. It's trying to keep really high rates of increase at something slightly lower.
Right.
Okay.
Thank you. You said that away. You said that better.
Yeah. So both the purchasers who are buying the coverage and the workers who are paying a portion of the coverage, they're both picking up the results of healthcare spending that's growing at twice the rate of people's wages. Yeah, nobody's spending is going down. Not close to it. Next slide. So all of these high deductibles and cost sharing result in elevated medical debt. And in fact, you heard from Mr. Kelly earlier about the problems of hospitals and other providers collecting co-insurance. So we're sort of in a vicious cycle where employers and workers try to manage fast-growing expenses by changing benefit design that leads to workers having to pay higher deductibles and higher co-insurance, which they really can't afford. And so that results in more bad debt. But all the bad debt is brought on by the fact that healthcare costs are high and growing at a fast rate. And so you can see here, a fifth of state residents with credit bureau records had medical debt in collection, and that ranked Nevada 39 out of 51 for residents experiencing medical debt. Okay, so again, per capita healthcare spending might be lower relative to other states, but the affordability perspective, if you look at it from the consumer level and from the employer level, does not look very good at all. So before you go to the next slide, I want to contextualize the next couple of slides. Ultimately, the perspective that we might care most about is the consumer's perspective and the extent to which healthcare costs are impacting how they access services. And what I want to share in the next slides is that high healthcare costs and fast-growing healthcare costs result in poor access. Okay, the two of them are related. I would say they are causally related. The higher costs are, the worse access is. And we can see that in the slides that follow. Next slide, please. So this is data from the Kaiser Family Foundation. Nevada ranks 6th in the country for the percentage of adults not seeing a doctor because of cost, and 10th for the percentage of children whose families had trouble paying for their kids' medical bills. Okay, this is one measure. The next slide has additional measure. These are data that Melinda shared previously. This was a survey conducted this past summer in Nevada, and 59% of survey respondents said that they had delayed care or gone completely without care in the last year, specifically due to cost. And you can see a breakdown of some of the things that they did: delaying visits, cutting their pills in half, skipping a recommended test or treatment. When 60% of survey respondents aren't accessing needed care, that's an access barrier. Next slide, please. Additional information from that survey. Half of uninsured residents said that the reason that they don't have coverage is it's too expensive. Now, Mr. Kelly made the point that a lot of the uninsured respondents, or a lot of uninsured residents, may be eligible for Medicaid, and that's an important point and something that, ideally we would like to see resolved. But people don't get coverage because it's expensive, which means that they then don't access services because they're uninsured a lot of the time. Two other points: 2 out of 5 people experience problems paying their medical bills, and 4 out of 5 are worried about affording healthcare in the future. Okay, so this is all pretty sobering if you look at a consumer perspective of the impact that healthcare spending is having on people getting coverage and on accessing services, even if they have coverage, because a lot of Nevadans and frankly, a lot of Americans are now underinsured. And that's because of the significant cost sharing that plans have. So let me summarize on the next slide. Healthcare spending in Nevada is lower than in most other states, but it's been growing faster than income. We see this in both premiums and deductibles. We have a high percentage of residents with a credit bureau record who are in collections right now for medical debt, and access to care is impeded by high healthcare costs. So the last thing I want to close with is, I'm going to paraphrase a little bit, but Mr. Kelly said, access won't be increased if reducing costs is the state's primary primary focus. I would say that looking at this information, clearly there's a need to focus on both cost and access. It's not one or the other. And as I think I demonstrated, there's also a causal relationship between the two. In fact, you all affirmed this at your last meeting when Melinda introduced a discussion of priorities for 2023, and you agreed upon both focusing on affordability and improved access. So I hope what I've demonstrated here is that there is a causal relationship between the two, and thus there's a strong rationale for your continued focus on improving affordability for Nevadans in 2023 and beyond. And I'll stop there and invite any questions you might have or comment. Melinda, do you want to recognize commission members?
Oh my gosh, I'm so sorry. Commissioner Bond, I see your hands raised.
Thank you. And I appreciate this. I really appreciate the counterpoint that you provided to what workers are experiencing, and it matches, our experience. I think what's missing from this, and I don't know how to get to it, and we talk about it every meeting in one way or another, is there's a lot of money being made by our hospital systems, and there's a lot of money being made by our insurance companies in Nevada, and we don't see the profit side of any of this data with all the work that we're doing on the benchmark. And all of this work of looking at what it means to a member to have, or a patient to have costs, we're not seeing how those costs relate to price, right? We have a gap of data about how much does stuff cost versus what is the price being charged. And I think with the hospitals, there's a lot of money that goes out of Nevada as well. So what kind of profits are being made by these hospital systems? What kind of profits are being made by the insurance industries that provide all these coverage? And how can we see that? Can we just see that? Because I think it tells a piece of story that this group hasn't worked on.
Yeah, I think certainly there's opportunity for you to look at that. And I can tell you from my work in other states that there are other states that do look at this. So there's no reason why this couldn't be something that you take on in the next year.
Okay, thank you. I think it would be great if we could get that on some, agenda to figure out how we could do that. I'd love some support in figuring out how we could do that. Thank you.
Thank you. Anybody else has a comment?
Not seeing any additional hands raised, Chair.
Thank you.
Thank you. That was great.
That was very helpful. We move on to the next item on the agenda now. Is the item number 10. Meeting schedule and activity priorities for the Commission 2023. Melinda, you need to take on.
Yes, thank you, Chair. So during the November meeting, the Commission gained consensus to meeting in person 1 to 2 times per year, with the Zoom option also offered for those in-person meetings, and would otherwise meet nearly completely virtual. And I say nearly completely virtual because one commissioner had offered the possibility for other commissioners who are local to the Las Vegas area to congregate and make a virtually held meeting at a physical location if other commissioners were interested. The question I want to pose to you all is 2 parts. So first, for the January meeting in particular, would you all be open to holding this meeting in person at the Grant Sawyer Building in Las Vegas with the Zoom option, of course? And secondly, would you like for that January meeting to be either on January 18th, which is the 3rd Wednesday of the month, or January 19th, which is the third Thursday of the month. So just wanted to put that out there. And I do see Commissioner McAllister's hands raised.
Hi, I understand why people want to meet in person, and I think I agree that it should happen once or twice a year. I request that it not be during flu season. Can we move our in-person to spring or summer when we're less, I mean, a lot of people on this call work in healthcare, and you'll be bringing those viruses from your hospitals into our meeting. Thanks.
Thank you, Commissioner. Any other comments, questions? Commissioner Ralston.
Yeah, I was just, is this a proposal to either switch it to the third Wednesday or third Thursday of the month? Is it only for January, or is this all for the subsequent meetings as well?
So kind of two parts, right? So first I wanted to get the January meeting figured out and then determine for the meeting cadence throughout 2023, you know, if the commissioners were open to the third Thursday or if we wanted to keep it at the third Wednesday.
Okay. For me, for January and even beyond, the third Thursday does work a little bit better for me, but I am certainly flexible. I'm not sure I can commit to being in person, but I do see that you do have a option to do in person with Zoom. So for those that can't go in person, we could still join via Zoom. Is that correct?
Correct.
Okay. I'm open to whatever is flexible for you and for the other commissioners.
Great, thank you. Commissioner DeSerbo?
Yeah, I would just give a slight lean to the third Thursday going forward if that doesn't create a problem. I'm fine either way, but just recalling our discussion from last time, it seems like maybe there was more consensus for moving to Thursdays. Correct me if I could be wrong. And I would support not being in person in January, but maybe for different reasons, just with it coming up pretty quickly, maybe that might cause travel issues or just scheduling issues for some. So maybe with a little more advanced notice, we could plan on being in person, and certainly springtime sounds great.
Thank you, Commissioner. Any other comments?
Hello, Melinda, I think for the commissioner's information, we had one commissioner who had some challenges with Thursday. Everybody else was okay. Correct me if I'm wrong, Melinda.
No, that's correct, Chair.
Right. So I think the Thursday seems like a major majority is okay. The question of a hybrid meeting, I'm okay either way, is whether we start in the only thing is it's a hybrid meeting. So those of us who cannot come or travel, they could still do it on Zoom as we are doing right now. So there is that option for those who want to go there in person versus those who cannot.
Can I just ask why we're moving the meeting? It's a pretty big reshuffle of my life to try to move everything to Thursday. I'll do it if we're having conflicts. I'll try to do it, but.
Yeah, I think just we had one commissioner, I don't know whether it's you or not, but everybody else is okay with it for this whole discussion. So I think let's see what we can figure out with your schedule, and if we can, that'll be great.
Okay, I serve on the Clark County, Southern Nevada Health District, and it's hard to not have those Thursdays free. But let me look at that calendar again too.
Okay, all right, great, thank you.
Thanks.
So for the hybrid, is everybody okay for January? Because you still have the option of Zoom.
I kind of agree
Yes.
about everybody's health, physical health, and that being a tough month. I kind of agree with Commissioner McAllister. Can we do it in the spring? Can we do it in April? The session starts, which is hard too.
Yeah, I'm open either way, as long as the majority is comfortable with it.
I do see Commissioner McAllister's hands raised, so want to recognize.
I'm sorry, because we're talking about two things at the same time. It's getting a little confusing, but yeah, so we meet in person in the spring or summer. And then also, just for the record, I can make Wednesday or Thursday work, but I have been missing a number of other Wednesday commitments this whole year. So I would prefer the Thursday just because I've been missing these other meetings that I only can watch the recordings of. I just want to put that on the record.
I think Commissioner Bond has very graciously offered to revisit her schedule, and hopefully something can be worked out on that. So about the spring and summer, any other comments? Is that everybody is okay with doing it in spring?
See a lot of head nods.
Okay, so I think if nobody is opposed to it, then Melinda, we can do it in spring.
Sounds good, Chair. Thank you. And then we will continue with the third Thursday of the month for 2023. Hopefully Commissioner Bond. Okay.
Right. Okay, let's see, where are we? Okay, so that's the one. The other one, next item on the agenda is public comment, actually.
Oh, quickly, Chair, I do have a couple more slides to go through really quickly. I apologize.
Oh, okay.
Thank you. So now I'd just like to transition to discussing the activity priorities for the commission in the next year. So during the November meeting, the commission agreed to focus on these two priority pillars for 2023, healthcare affordability and healthcare accessibility. So healthcare affordability will continue to focus on the Peterson-Milbank Program for Sustainable Healthcare Costs and the Nevada Healthcare Cost Benchmark. I'm also happy to announce that Nevada's support from the Peterson-Milbank Program has been authorized for another 2 years, which is very exciting. So, however, the technical assistance we currently receive through Baylor Health will be reduced in this next phase, but they'll still be here. So therefore, the Peterson-Milbank Program has asked me to draft how Nevada might like to prioritize the technical assistance requested from Baylor Health. So if you have any ideas on how we could prioritize this technical assistance in 2023, please feel free to speak up during this discussion or reach out to me at any time. I expect to develop these priorities within the next month. Peterson-Milbank has similarly identified that in this next phase, in addition to the technical assistance from Baylor, specific support for Nevada is likely to include analytic support to understand cost drivers, communication support for effective dissemination and stakeholder engagement, and convenings for cross-state exchange learning and peer networks. So for the first pillar, is there any initial thoughts or discussion for that first pillar? Commissioner McAllister.
Hi, so for the, learning from other states, I find that very valuable. And back to Commissioner Bond's comment of how do other states tap into the data of profitability within the healthcare systems in their state? How are other states discovering this information that seems to be behind a cloud in our state? So I would move that to be a priority.
Excellent. Thank you, Commissioner. Appreciate that. Any other comments? Vice Chair Rubelin?
Yeah, I just had a question. Would there be any technical assistance with our BDR that's trying to codify this work? Would that be included or should it be included?
Yes, so it's my understanding that we will receive technical assistance related to the cost growth benchmark BDR during session.
Thank you.
Mm-hmm. All right, so now I'm going to move on to the second pillar. So under the second pillar for healthcare accessibility, we had a great discussion in November surrounding the potential to survey medical and nursing residents statewide to determine what motivates them to either stay or leave Nevada after completion. I understand that a survey along those lines is currently in the works in Southern Nevada, and the Commission expressed great interest in developing that type of survey statewide. In addition, if the Commission is in agreement, our state DHHS PPC team can perform an environmental scan of work that has already been done in the state to improve healthcare accessibility, including workforce strategies. We then propose the idea of bringing the results of this environmental scan along with a broad array of ideas to the Commission in March for consideration under this pillar for how the Commission can help move the needle in a positive way for healthcare accessibility in our state. So open to any comments or discussion here as well.
So a lot of work has been done, I know, by various agencies and the medical school, especially with UNLV as it was evolving, regarding what motivates people or discourages residents or students to stay in Nevada. So as long as we are not reinventing the wheel, UNR has also had its studies. I think the first step would be to see what information they already have. And if they already have more than enough or enough information and the studies have been done, then we may be just duplicating that effort overall. So that's my view on that survey. The other one on this environmental scan, what does that really mean?
So thank you, Chair. In my mind, that would be determining what work has already been done in the state to affect healthcare accessibility in a positive way. If there are any, reports, commissions, committees that were developed in the past to address this issue, and to review those, and then, come up with a menu of ideas per se for the commission to discuss, and then of course open to any thoughts from anyone on how the commission might further address healthcare accessibility in the next year.
So on this one, the same view I have. I know various groups have done that study, the challenges for healthcare access, feasibility, accessibility, etc. So my suggestion would be in these two items, let's collect whatever is available out there and then talk perhaps at the next meeting that this is what is available or this is outdated, whatever it might be, and then narrow it down to areas that potentially they may not have addressed rather than duplicated.
That sounds great, Chair. Any discussion on that?
Anybody has raised their hand, Melinda?
I see Vice Chair Rubelit's hands raised, but I think that might be old. Yep. I do not see any hands raised, Chair.
All right. Okay. Thank you very much.
Oh, I just have one more slide. I promise.
Oh,
I'll
you
be
still
super
have
fast. One more slide.
Okay.
So I just wanted to give you all a quick snapshot of what we are expecting to accomplish in the first few months of this next year. So, as you can see, we've incorporated the 4 healthcare cost growth mitigation strategies, further exploration discussions into the first 4 meetings of the year, along with the phase 2 cost driver analyses from Medicaid and the Public Employees Benefits Program, and of course, our first baseline benchmark findings report. So open to any thoughts or comments on this slide just before we conclude this agenda item.
Anybody raise their hand?
Seeing none, Chair.
All right. So do you have anything else, Melinda?
That is all, Chair. Thank you so much.
All right. Thank you very much. So the next item is public comment. Do you have anybody for public comment?
If you would like to have public comment, please use the raise hand feature in the Zoom platform, or if you are calling in, please press *9 on your phone to raise your hand. And I do see that we have public comment from Barry Cole. Barry, please go ahead.
Thank you very much.
Just a reminder.
Sorry, my name is Barry. Oh,
go ahead. No, just a reminder. We normally have 3 minutes for public comments, so FYI.
Won't need them.
Okay.
I'm with the Nevada Psychiatric Association. Just to let you know, in our February business meeting, that'll be in mid-February, we're having parallel essay contests for all medical students in the state of Nevada and all psychiatric residents in the state of Nevada. We're asking medical students to tell us what they foresee as need to remain in Nevada after they've completed medical school. Will they commit to doing residencies here? And then for our residents who are graduating from our psychiatric programs, the goal will be to identify what would help them commit to staying in Nevada. Currently, we're losing 3 out of 4 of our psychiatric residents at the end of their training, and they're being picked off primarily by California and Utah, who can outcompete us. So I can come back to you maybe in your February meeting and tell you the ideas that medical students and residents have right now, and that will be part of our planning for going to legislature to ask for ways to make this better for medical students and psychiatric residents. Thank you.
Thank you very much. I would suggest if you could please forward the information ahead of our meeting so it can be distributed to the commissioners so that they would have had a chance to look at it and then ask you educated and informed questions. All right, and anybody else has any comment on this? Public comment?
Any other public comment? I'm not seeing any other hands raised, Chair.
Okay, so if there are no more public comments, the last item on the agenda is adjournment, right?
Correct.
Okay, so the meeting then stands adjourned, and thank you very much, everybody, for your time.
Thank you, Chair Khan. Goodbye, everyone. Merry
Bye.
Christmas.
You, happy holidays.
Thank you.
Yeah.
Merry Christmas.
Merry Christmas.